Hey, good morning. My name is Mary Leonard. I'm chair of the Department of Pediatrics. Such a pleasure to welcome you to this Pediatric Grand Rounds. Just one quick announcement for the folks from the Department of Pediatrics, and that's we have a virtual town hall on April 8th on Monday, specific to research questions, and so helpful if people can click on the link in advance where you can enter your questions so we can make sure that the research team, Gary Shaw, John Whiten, Crystal Botham, and myself can have those answers for you. I also want to make sure that I draw everyone's attention to the upcoming grand rounds. We had a question at the Department of Pediatrics broader town hall this Monday about ethics, resource allocations, ventilators. And in the process of getting ready to answer that in advance, I reached out to David Magnus, who told me the ethics team has been doing disaster planning for very long time, and that Alyssa Burkhardt and Holly Tabor are already very much working on the COVID-19 question. And so we're so pleased that they're going to be giving us grand rounds a week from today. So we want to make sure that, ethics in the era of COVID-19. So want to make sure that everybody, saves the date a week from today. And with that, we will move forward with today's session. I want to introduce our speakers. Lisa Chamberlain is known to many of you. She's a professor of pediatrics and the Arline and Pete Harman Arline and Pete Harman faculty scholar, and she is the associate chair of policy and community engagement in the Department of Pediatrics here at Stanford. As we envisioned this role, and Lisa came into this role, we learned that her overarching goal is to improve the health and the well-being of vulnerable children. And that's through multiple strategies. One is to perform health services research that informs health policy. The second is to redesign pediatric primary care by bridging health and education sectors and training the next generation of pediatricians committed to reducing inequality. As part of that, many years ago, she founded a very unique track within the pediatric residency, the Stanford Pediatric Advocacy Track. This is a nationally replicated program that trains pediatricians to address child poverty through community and policy engagement. And now there's been part of pediatric requirement. Of note, the very distinguished graduates of her program include Nadine Burke-Harris, who many of you know is recently appointed as California's first Surgeon General, and also the only pediatrician in Congress nationally, and that's Kim Schreier. She is a W.T. Grant Foundation's Distinguished Fellow and spent time in Sacramento as part of Senator Richard Pan's Health Policy Advisor from 2014 to 2016, where her health services research was used to reform California's Title V program. And it's very inspiring to see the busloads of residents so she's taken to Sacramento. Last but not two more things, she co-founded the California Collaborative, which trains over 800 pediatricians a year, now modeled in 8 other states. And finally, as part of the university's long-range planning, President Tessé Levine asked her to co-chair Stanford's University Precision and Population Health Initiative. Lisa, good morning and welcome.
Good morning. Thank you, Mary. Appreciate the introduction and really appreciate the opportunity to join Paul Wise this morning as we talk to you about confronting COVID-19 in low-resource communities, local, migrant, and global settings. I always like to anchor talks in a clinical case. So this is a child that I saw just this week on Wednesday, a very young former preemie, had spent a good amount of time in our Packard NICU. Only chief complaint today was still not taking great feeds by mouth. This is a kid who'd had a very complex stay, and the plan had been to see multiple specialists upon discharge. But those appointments had been rescheduled because of COVID, with the exception of the occupational therapy appointments, which were still continuing by phone to kind of work on the oral feeding. On exam, baby's weight was okay, growing all right, so that was great, and development was on track. As I continued to see the family and talk with them, with the resident in the case, the father brought up further concerns. He told us that he hadn't worked for the last 3 weeks, was very concerned about the ability to pay rent, was unable to find and buy diapers, and only had enough formula for the next 3 weeks. And as I thought about this case, we wouldn't count this patient as one of our COVID patients, a kid who would be directly infected. But this child and their family certainly has a great chance of being impacted very much by COVID. And this brings me to a key concept of this talk, which is that disasters have both indirect and direct impacts. In the case of COVID, the direct impact comes from the virus itself. Very serious infection for many people can cause hospitalization and even death. And so that is clearly a huge threat to all of us. There are also indirect impacts, and that comes from our public health response of needing to shelter in place to reduce the direct impact, which is absolutely critical. But with that sheltering in place comes other kinds of consequences, things that can also impact our families, such as unemployment and educational disruption. It's almost like the Spanish flu and the Great Depression kind of merged in this one, since we are seeing both direct and beginning to see these indirect impacts. And history does have much to teach us about disasters. We have certainly been here before in some ways, although it was different. Here, I did some Katrina relief work after the hurricane in the Walmart parking lot there in Louisiana. And I saw both the direct and indirect impacts of Hurricane Katrina. The direct impacts, I was there a couple of weeks afterwards, so it was healing, abrasions, basic things. I refilled a lot of prescriptions. But most of what I did was listen. I listened to the families, I listened to their stories, I listened to their trauma and absorbed what they had been through. And what they and their families had been through was quite a lot. Researchers followed many of these families to understand what the long-term impacts were of Hurricane Katrina following that disaster. There were high rates of depression, anxiety, and PTSD later in adults, and 36% of children 4 years later had serious emotional distress. I was lucky to be able to take care of some Katrina survivors when they had moved to the Bay Area following the event, and got to know their families. And one of the things I really want to stress was how resilient these families were. They were able to restart their lives with all sorts of energy and excitement. And so I really want the idea to come across that there's incredible resilience and strength despite these kinds of challenges. But we do know that overall for a population, these kinds of disasters can have significant long-term effects, especially for children. A more recent example of a disaster was the Great Recession. Similar to the COVID in the sense that it was not a displacement situation where a lot of people were moving, but it certainly was very disruptive in terms of families having food insecurity and significant housing insecurity, which is something that really brings us to today with our current disaster, the COVID pandemic. This is a picture of Dr. Sarah Cody. We are very proud of Dr. Cody as the Public Health Officer of Santa Clara County. She is a Stanford alum and doing an extraordinarily good job here. She is being nationally lauded for her vision and her leadership in steering us through this current crisis. And it is she who introduced us to the term now, shelter in place, which is a term I'd say a month ago many of us had never heard of, and we are all now incredibly familiar with. And this is saving lives. We know with the curves that we're seeing that it is the right thing to do. It is what we must do to blunt the direct effects of COVID. And at the same time, we need to prepare for the indirect effects that are heading our way. This is a news release that came out just yesterday from the Department of Labor, talking about the unemployment applications. 2 weeks ago, we had 3.3 million initial claims filed, and that went up to this released yesterday to 6.6 million, which marks the highest level of seasonally adjusted initial claims since we have been keeping this kind of data. And if you're a more visual person, this is what it looks like in the same press release. On the bottom, you have months over the last year, and on the y-axis, millions of people who are filing for unemployment claims. And you can see that it has been quite low and quite steady for the last year. So that's really the good news. We're starting from a very healthy place in terms of employment, but you can see the sharp uptick on the right And I'm afraid that uptick has just begun. So we are beginning to see these indirect impacts. And I have to say that as I was getting ready for this talk and doing a lot of reading, it was feeling a little overwhelming at times in terms of what is headed our way. But at the same time, I really want to convey that I think this is an incredible opportunity for us to come together as a community, as a pediatric community with our community partners like we never have before. We're going to need to do that to get through this together. So let's move on to talk about who is the most vulnerable during this time. And I would say that children with medical complexity are intensely vulnerable. They require seamless access to subspecialists, to their medications, and their equipment. They also require very healthy parents and caregivers. And we have great strengths here. We have Dr. Lee Sanders and Karen Wayman, both who are very deeply involved at our Children's Hospital through the CORE program with Karen, and Dr. Sanders, who leads the Complex Primary Care Clinic. Both of them are supported by the Lucille Packard Foundation for Children's Health, who is a national leader in thinking about children with complexity. I asked Ann Rose over at the foundation if she could send me some information about what the foundation is doing at this critical juncture. And I loved this response. Our mission has never been more important. Our supporting friends at the foundation are out very, very busy working to support all of us through strategies of amplifying faculty expertise, sharing patient stories and care providers. You can see over there to the right, a little guy holding up a sign. They had a social media campaign and had over 200 messages posted for physicians and caregivers, and working to provide ways for the community to support the hospital and the school. They've received many offers of people from our community saying, how can we help? So they've created a response fund and are supporting gifts that have supported PPE and different kinds of germ zapping robots and all sorts of fun things like that, and help support faculty research projects. So shout out to the foundation. Thank you so much for your continued support. Karen and Lee really need that support as they help our families with their predominant challenges. And I want to acknowledge and thank Lee Sanders for sharing this slide, which I've adapted for this talk. The challenges involve coordination challenges. Over 35% of kids report unmet healthcare needs. Access to care for our children with complexity, 1 in 3 are on Medicaid. And in terms of community services, 1 in 4 US children live in poverty. All of these areas are impacted by COVID. In terms of coordination of care, they're already hearing from families that medication deliveries are being interrupted. And in addition, supplies such as feeding tubes and things like that are also becoming more difficult to get. In terms of access, families are afraid. They're afraid of having decreased access. They're concerned about the appointments being delayed. Also, with the conversations in our communities and in the media around ventilators and shortages, they worry that if their child were to need something, it wouldn't be there for them. And in terms of community services, as I heard in that clinic visit just the other day, our children with complexity are facing new levels, really unprecedented levels of food insecurity and unstable housing. But they are hard at work. Very proud to say that Karen Wayman leads a very nimble group and has quickly responded to support our families. Here's pictures of them all in action, supporting our patients who are inpatients by reaching out to isolated parents, conveying the things from our command center around policy changes, reviewing hand hygiene and social distancing, escalating care to our social workers, just very busy wrapping their arms around our families who really need them. In addition, her CORE program is reaching out to their 420 families, 120 of which are in the Complex Primary Care Clinic, and are committed to connecting with each patient every 2 weeks, which is a remarkable undertaking. So thank you all very much for your response to our families at this time. I think in another way that we need to really be nimble is we need to think about the impact of our rapid deployment of telehealth. First thing I want to do is thank Natalie Pagler. Her picture is there. She's an extraordinary leader in helping us all move to a telehealth model. And here you can, on the right, see our pediatric residents very busy making their telehealth calls. This has been an unbelievable shift for us, and it has happened almost instantaneously. And I think it's important that we really reflect on this shift. Telehealth has a real opportunity to either reduce or drive disparities. It could reduce or increase the differences in our outcomes for our children. And our ability to understand that and mitigate that relies on our ability to ask smart questions and answer them so that we can do this in a really thoughtful way. Questions such as, is there equal uptake across our families? How does the move to telehealth improve care? Does it improve outcomes? Do we have some worse outcomes? And one question I think is really interesting is, how does this vary by field? How does it look different in nephrology versus GI versus cardiology? These are questions we don't know the answer to. And I think that it really provides an incredible opportunity for us to ask really smart questions so that we can inform this incredible shift that we're undertaking right now. For my health services research team, this is actually number one on our agenda to talk about next week. So if people are interested in thinking about those questions, please do reach out. So I want to shift here from those children who are vulnerable because of their medical complexity to those who are healthy and living in our communities but aren't thriving. So we live here in a very densely populated area on the peninsula where nearly 1 in 2 children live in poverty. This is an aerial shot, and what you can see there is that most of the children are born in the Stanford nursery and then are followed throughout their life, and if they don't move, across these clinics. The county clinics of Fair Oaks and up at San Mateo General, our Gardner-Packard Clinic, the federally qualified health center of Ravenswood Family Health Center, and then the Mayview Clinic. So it really are these 5 clinics that care for the vast majority of low-income children in our community. And about 4 years ago, I reached out to the pediatricians in those groups, and we formed the Mid-Peninsula Pediatric Advocacy Coalition. And we've been meeting every other Thursday for the last 4 years, and we like to think that we practice population pediatrics. We work together across all these clinics to bring different interventions, such as increasing mental health access and early childhood literacy programs. About 2.5 weeks ago, we reached out to our community partners as we saw this COVID indirect surge coming, and said, wow, we need to really band together to help understand how we can best support our families in this situation. We've reached out and brought together many of our old faithful partners that we've worked with for many years, including some new partners like the primary school. And I really want to deeply commend Dr. Janine Bruce, whose picture is there, who is a working partner of mine for many years and deeply known to all these community partners. So when we brought them together, we started to say, let's talk about our shared resources and what can we do to support one another. Immediately, one of the best resources that popped up is this amazing app that a group of Stanford graduate and undergraduate students across these different fields created. And what it has done is mapped out all of the school lunch sites that are currently open during even during the school shutdown, so that families can still continue to receive nutritious food for their children. This is mapped for the entire Northern California area. So even if we have our patients who are coming from far away, this would still work for them. Really appreciate that from our undergrads. So if I click on one, I just clicked on the East Palo Alto area there, and you can see Castagna School pop up, and there's all the information listed, its address, when it's open, what kinds of food, and some notes. So it's an incredible resource that we're all using. So what do these feeding programs look like? Here's what it looks like in East Palo Alto at the Ravenswood School Meal Program. It's an incredible group of dedicated staff who are working through this school closure to make sure that the kids get their meals. And it's under the direction of June Richardson, who I couldn't think I could like anymore. And then I found her yesterday on Twitter. So her stock even went higher. This amazing program that she has set up is currently serving 2,400 meals a day 12,000 meals a week, feeding almost 5,000 kids. And she's done a couple really innovative things, which is that 32% of these meals are being delivered in a reverse school bus kind of way. So for the families that can't make it to pick them up, they can have them delivered. And another really amazing thing that she did was over spring break, the children also received meals. So the kids are currently in East Palo Alto on spring break this week, but they had breakfast and lunch all week to be able to get through it. And so we thought, how can we amplify this? And I really want to commend Anisha Patel, a colleague of mine, General Pediatrics, who, when she heard about this, she jumped on it and reached out to her partner at the Nutrition Policy Institute to do kind of a best practice white paper describing why it's important that kids do have hunger over spring break. So hunger doesn't take a spring break, and they put together this great brief report that is being disseminated across the state so that all schools can model after this. So I think it's important the way we can nimbly really identify these incredible opportunities and use our networks to share these ideas. So how can we build even more capacity there? The children are receiving meals, but the parents are not. And the younger children, the 0 to 5, also need food support. And so we're working with Second Harvest Food Bank to think of how we could, at the same time, while the meals are being picked up for the children, also provide some food for the families. They are currently doing that on Saturdays, but how could we do that maybe Monday through Friday? And just yesterday, in a conversation with Second Harvest Food Bank, they shared with us that the number of calls they're receiving has gone from 200 to 1,000 per day. And in addition, they have had to close 75 distribution sites for their food because they rely greatly on volunteers, and many of their volunteers are in a higher risk group in terms of their age, and so they've lost many volunteers. So they're really asking for help. This is a rapidly evolving situation, and I would really love to think with people about some innovative ideas of how we can strengthen this incredible community partner who is doing incredible work. Another inspiring example of work happening in our community, I learned about through Dr. Dana Weintraub, pictured up there on the right. The Boys and Girls Club of East Palo Alto and Redwood City really are an extraordinary organization, and they have immediately stepped up to the bat and also started a meal program at night. So this is a supper program, and they have served almost 750 meals per night, but that number's been going up in both of their sites. And here's some pictures of, again, incredible volunteers who are doing great work for our community. Related to food shortage is this formula shortage. So we have heard it now in clinic a couple times about families who are concerned that they don't have enough formula. And I looked into this with the American Academy of Pediatrics. They really believe this is not a supply chain manufacturing issue, so it's more of a panic buying issue. And for that reason, they think that it will right itself soon, but that has not yet happened in some places. I find a great resource is this healthychildren.org. So if you're looking for information and how to talk to your families about that, I really would direct you to AAP's healthychildren.org, and we will keep an eye on that. For our impact meeting this next week, we have invited the directors of WIC, the Women, Infant, Children program, to come and talk with our collaborative about what they are doing and how we can better partner with them. And we're interested in an idea of bundling formula and diapers so that families could get both together. So that's another program that we're looking at. So moving from food to housing, rent was due April 1st. So Wednesday was a day that was very stressful for many people. We co-opted our impact meeting this week to help co-host a webinar that was joined by over 50 community partners on the Mid-Peninsula to learn about how California's new ordinances, moratoriums on evictions, are impacting our families. And that was led by Shawnee Stevenson from the primary school and lawyers from CLESPA. So good information there. We have a recording of that, and if people are interested, we can help make that available. More on moratoriums on eviction in our advocacy section that I'll get to soon. So with all of our partners, we realized there are so many resources out there, food resources and housing resources, et cetera. So what we've done over the last couple of weeks is try to bring all those new resources together. So there are many lists of great community programs, but what are the organizations that are doing different things to respond to COVID, have new things to offer? So we brought all those resources together, and then we took them to our community partners and we asked them, what would you prioritize? What do you think the community needs the most? And from that, we were able to generate a new handout, a new flyer. This is what it looks like. On the top there in green are the food resources, followed by housing support, and then legal help. It was interesting in our conversations with our community partners, it immediately came up, I don't know, 5 minutes into the conversation, immigration fear is still a big concern. So even as we're talking in these really difficult times about primary services, make sure that we always talk about how these are things that will be safe for families to avail themselves of. So that is always hovering right in the background. So this flyer, we want this to be available to everyone. We've partnered and worked with our social workers. Thank you, Kim Brown and Liz Figueroa, for your hard work in working with us. An epic dot phrase is coming so that you can access this for our inpatients or anytime you're on Epic. And this flyer will be available on the LPCH landing page. We are also, in addition, going to be mailing it to all of our Gardner-Packard families, so it'll go out to about 5,000 families that way. And we'll be handing it out in the Ravenswood School District meals, so when the families come to get their meals, they will also get a flyer. And we're looking for other ways to get this out there because we really want people in this difficult time to know that there are a lot of resources there for them. And I love being able to thank Melanie Ramirez in our Peds Advocacy Program, her pictures there, who has just done an extraordinary job navigating all of this and helping to bring all of this together. So thank you very much, Melanie. So shifting from disruption economically of our resources to educational disruption. I know all the parents out there, I feel you. I understand how hard this is. It's the headline from the Palo Alto Weekly on Wednesday, and this is a outtake from the email I received the other night where the superintendent of schools says, with the authority granted in me, I'm closing school. So we are out now for the rest of the year, which is a blow. It's a blow for a lot of people. And just like how, as doctors, we've had to jump to telehealth, educators have had to jump to distance learning. So we're all kind of making this jump to hyperspace together in parallel. And this can feel really overwhelming, as everyone can imagine. And I think what we're hearing is that education and distance learning really requires strong technology, broadband access that is equitable, that everyone can reach, so that we don't drive those disparities. And that has really depends on the technology gap that exists. So as we've met with Gina Sandaria, who is the superintendent at Ravenswood City School District, she told us about 300 new Wi-Fi hotspots that have gone up recently in East Palo Alto to help mitigate this, but they still feel about 100 more are needed. In addition, they are distributing Chromebooks to all families that need them. And so the Sequoia district is doing the same. So people are moving quickly to try to make sure that the infrastructure is there so that all kids are able to keep learning during this time. But there are special populations. What about our youngest learners? What about our preschool kids? Promise Venture Studios has put together, they're one of my favorites, have put together some great resources there, but so much more to do. And then challenges in terms of children with who have special education issues and needs. How do we make sure that those needs are met? And I appreciate Heidi Feldman raising that issue for us. Thinking about education and how it's being impacted and the disparities that this is going to drive really can be really overwhelming. And I've only just scratched the surface here because it could be a talk in and of itself. But one of the things that I think it's really folly for pediatricians to think of trying to remedy or participate in a solution on this on our own. I think turning to our School of Education here on campus it's an incredible resource, nationally known for its work in this area. as well as the John Gardner Center, which is a part of the School of Education that specifically works with youth in their communities. And so I reached out to Dean Schwartz, and he assures me that there's, quote, a lot of action going on over here around these issues. And so I hope that there are opportunities for us to work together and partner to think about how we can help smooth the educational and distance learning transition together. Shifting to advocacy, a lot coming out of Washington to try to address this growing crisis. These are the three primary bills that have come. It's just like a fast train coming out of there. These different bills have addressed many issues, including extending unemployment benefits for families, direct payments to families that make less than $75,000 for one, $150,000 for two. That'll be administered through the IRS. Food banks are to receive $850 million boost. In addition, utilities companies, so that we can keep electricity turned on for families who can't pay their bills. This is just a very brief summary, but a lot coming out, and we anticipate more large bills that will come forward to help support our communities during this time. Moving to the California policy landscape, California is very busy implementing those things that are coming out of Washington, but they also are we are also putting some of our own things in place. Eviction and foreclosure protections have come out of Sacramento most recently. They've made testing free for medically indicated COVID tests, but there's a lot more we can do. We can look for more PPE to be available in our community clinics and in our mental health clinics. In addition, how do we support community clinics when they have low volumes due to our new protocols around telehealth, so that we don't have to lay folks off, and just other supports to make sure that telehealth can be evenly rolled out. And when we engage our voices in Sacramento, it really is a team sport. It requires uniting our voices across many different groups. And right smack dab in the middle there is Sherry Sager, our Chief Government Relations Officer, and she has just been an absolute key guiding voice for all of us in terms of thinking of how we can unite our voice for our families. And can't say enough good things about our Resident Advocacy Council seen there on your left. This is a group of residents that we are constantly in touch and advocating around a lot of different things. They have incredible energy and spirit, and just an absolute pleasure to work with. When we do have different issues that come up that we're going to advocate for, we reach out to our partners across the 14 training programs there in California. The faculty are all in touch closely, so we can magnify our voice that way. In addition, the American Academy of Pediatrics in California, under the direction of Chris Calvin, has been just remarkable in terms of being very supportive of our issues. So we've got incredible partners. And a recent example where we worked with Chris was about the eviction moratoriums. So I had reached out to her that there was going to be an eviction moratorium heard last week in Redwood City. And, where was the AAP on this? She immediately went to work and put together this lovely letter that talks about the American Academy of Pediatrics, how it represents the pediatricians in California, and how this kind of position would be very supportive of our families. We were able to take that letter, put it out in our action alert, send it to many of you so that you could learn about this and join in using a Google form to support it if you were interested. So that brings me to our action alerts. If you didn't get this information in your inbox, you must not be among the 200 people who get our action alerts, which we send out every other week or every week, depending on the volume going on. So this is the example of what was sent out last week. It has this advocacy update, talks about the eviction moratoriums, talks about different community organizations if you're interested in donating or volunteering. So if you are not on this child advocacy listserv and you would like to receive it, please send Melanie there an email so that we can get you added. I think another important way for us all to be raising our voice right now is by using and utilizing social media. So social media is an incredibly powerful way a new opportunity for us to engage in the policy process. It is indeed become the way that our leaders are communicating with us in many ways. And so I think this is an important place for the pediatric voice to be heard. Our, again, intrepid residents have set up an Instagram page where they're doing lots of great advocacy. We have a Twitter account for our advocacy program, and I personally am on it, so lots of opportunities there. And up in the right-hand corner is a picture we just took with the GI division. So the different divisions across the department have been meeting with me and getting busy on Twitter, talking about and advocating for things that are specific to their patients. And if we're starting to have shortages around G-tube materials or other things like this would be a great opportunity for us to raise our voice nationally. I mean, it immediately goes and reaches our policymakers when we tag our elected officials. So I think that this is an important place. We've been working to get as many of us who are interested engaged in social media. So I'm glad we have some of that infrastructure, and I'm really interested in continuing to build that. So there are many ways for all of us to participate, and I really do think we are going to have to come together at this time to face this challenge together, and I know that we can. For those of you interested, you can click that QR code. It'll take you to some web page here where you can download that flyer directly, places we can recommend that you donate, or opportunities to volunteer. In addition, please feel free to reach out to me. If the different things that talked about today sounded interesting, or like things that you would like to help with and participate in, please do reach out, because we really are all in this together. Both the direct and indirect impacts of this pandemic are going to be felt by our families for quite some time. The direct impacts hit across all groups, and the indirect are going to disproportionately really affect just some of our families. So I think we have to do all that we can to mitigate these impacts, and to do so, we all must act together. So I look forward to doing that with you. So at this time, I'm going to stop, and as it concludes my portion of this presentation, I'll stop my share. So Paul Wise is the Richard E. Behrman Professor of Child Health and Society, and a Professor of Pediatrics in the Division of Neonatal and Developmental Medicine and Health Policy at Stanford. He's also a Senior Fellow in the Center on Democracy, Development, and the Rule of Law at the Freeman Spogli Institute for International Studies. So with that, I'll hand it over to Paul.
Thanks very much, Lisa. I must say that it's just remarkable to see how much you and your colleagues are doing to address the threat of COVID-19 in local communities. What people may not know are the years of creativity and hard work that has gone into building such a strong and dedicated infrastructure of advocacy and action. This infrastructure under your leadership has been extremely nimble in turning its attention so quickly and so effectively to address COVID-19. It really is a critical resource for our local communities and also for this department and hospital. I'm going to build upon Lisa's presentation regarding the most vulnerable low resource communities to discuss our work in addressing women's, children's health in areas of violent conflict and profound political instability. We have a series of activities around the world with colleagues and organizations based at universities and in the field around the world, and together, which we have labeled the Children in Crisis program. I'm going to begin by talking about one of the most vulnerable groups of children right now, migrant children from the Northern Triangle of Central America and Mexico who come into U.S. immigration detention along our southern border. Last year, more kids came across our southern border than any other time in our history. Almost 80,000 unaccompanied children were apprehended by Border Patrol or through the ports of entry on our southern border. Kids in families were more than 300,000 in number over the last year. And this was an unprecedented number of children who came across the border and wound up in US custody. I should point out that virtually none of these kids or families try to evade apprehension. They come across looking for Border Patrol to give themselves up for seeking asylum. And I just want to take a minute to just talk about the system that's in place. I get a lot of questions about exactly what happens to children and families when they come across the border. They're first apprehended by Customs Border Protection, it's CBP, it's Border Patrol. Unaccompanied children, kids who have no parent with them, are transferred to the Office of Refugee Resettlement, ORR, which is run by the Department of Health and Human Services and placed in either large shelters or foster care. Families with children generally go to Immigration Control and Enforcement, ICE, and they have detention facilities as well. There are some special cases, pregnant women in their last month of pregnancy or people with significant health problems that may get released to sponsors in the United States. And basically, this is what you saw on TV, pictures like this that went viral. And ultimately became infamous when the administration implemented a zero tolerance program, which basically separated children from their parents and sent the kids, basically creating unaccompanied children to ORR and sending their parents into ICE detention. That was rolled back once it became public, and the backlash politically was quite severe. However, it did elevate the public concern over what was happening to children in US detention, which was exacerbated when several young children here from Guatemala in US detention died, what apparently was from influenza, and which ultimately led to legal action under what was called the Flores Agreement, which was signed in the Clinton administration to guarantee safe and sanitary conditions for children held in US immigration detention. However, a temporary restraining order was filed, and in June it was granted because of concerns over overcrowding and mistreatment. And shortly after that, actually, I was appointed as the special expert independent monitor to the federal court overseeing treatment of migrant children in US custody. And my job was independent assessment and assist ongoing mediation between Homeland Security, Customs, Border Protection, Border Patrol, and the class council advocates for the children. And I must point out that Stanford Pediatrics is the department at the center of all the activity related to kids in detention on the border, because Ewan Wang of Emergency Department, Pediatric ED at Stanford, is the lead medical consultant to the class council advocating for the children. Now, getting to COVID-19, the CDC WHO guidelines, everybody is quite familiar with. But how do you do these things here? How do you protect these families and these kids from COVID-19 when you have conditions that look like this? And just last week, temporary restraining orders were filed against ORR and ICE because of concerns that they will not be able to protect children in detention facilities from COVID, and the idea was to have them released as quickly as possible to reduce their vulnerability. And that was granted. I was asked to monitor compliance with this TRO, and the judge just Saturday night issued the temporary restraining order, which has moved everything into mediation to try to prevent COVID-19 from really threatening the health and well-being of all these children. And basically what the response has been is basically to turn all the families and children back to Mexico or quickly send them to Central America. In other words, not even to allow them to come into the ORR or ICE facilities, but to basically empty out Border Patrol detention facilities as quickly as possible by turning them back as an effort to reduce the risk of COVID-19 in these areas. The challenge, of course, is this is what happens on the Mexican side when you turn people back. And migrants in Mexico are a focus of a lot of concern with COVID-19. And I should point out that at Stanford, Families at the Border initiative, not surprisingly, under Lisa's leadership, is actively engaged in addressing issues of health in Tijuana. And colleagues at UCSF, UCSD, and here at Stanford are working on the Border Humanitarian Health Initiative, which is addressing a collaborative approach between US-based and Mexican-based humanitarian organizations to address these issues. I also want to turn now from the migrant vulnerabilities to the broader issues of how do you confront COVID-19 in areas of extreme vulnerability, particularly the areas in violent conflict and political instability, the areas that the Children in Crisis program have been working in for a number of years. These are models looking at the potential of doing nothing around COVID-19, doing suppression activities, basically the CDC recommendations early or late. And basically what you see, and may be somewhat surprising, is that some of the poorest areas on the planet may not contribute the most deaths. And that's generally a reflection that the poorest places on Earth are younger populations. Their demography is not as vulnerable to mortality from COVID-19. But what it basically says is that early suppression will save lives. So how do you do this in places like this? This is the city of Mosul in northern Iraq, which is taken over by ISIS. And after Mosul was taken back by Iraqi security forces with US coalition backing, Mosul looks like this. And people move back in or are living here. How do you stop COVID-19 here? How do you address COVID-19 places like this, where huge displacements of populations are living in refugee camps around the world that look like this? Areas that have been ravaged by humanitarian catastrophes like here in Yemen, where cholera, malnutrition, and ongoing fighting has created the worst humanitarian crisis in the world. And humanitarian health requirements require access, local support, you need a protected supply chain, and you need security, particularly now because not only are these areas insecure, but belligerent groups, the combatant groups, have actually begun targeting humanitarian health facilities and workers in these areas. And we're part of the leadership team of a new Lancet initiative that will be published later this year, addressing the humanitarian requirements for maternal and child health services in areas of violent conflict. It's not only areas in formal conflict, but many of the urban areas around the world, here, favelas around Rio, that are controlled not by the government, not by the local police, but by criminal gangs and militias. How do you begin to address COVID-19 in areas like this? And what is particularly troubling is without the ability to have good governance, legitimate governance in these areas, and for people to take things like securing in place, going to lockdown voluntarily, your only alternative to legitimate governance is coercion, where responsibility for pandemic control moves immediately from the Ministry of Health to the Army. We saw that in West Africa, Ebola outbreak. How do you do this in these areas? Well, we've been working with colleagues at the London School of Hygiene and Tropical Medicine, Hopkins, with organizations, humanitarian organizations around the world to begin to address this and address this quickly. And one of the recommendations is what's been called radical shielding. It's reverse isolation. It's not isolating the sick, it's isolating the most vulnerable, healthy individuals in these kinds of areas, particularly the elderly and those with chronic illness. And we can do this in a variety of different ways. And what I'm going to describe is one illustration of how we're trying to do this in one of the most vulnerable places on the planet. And what we're trying to do is to take advantage of what's been called task shifting, to use community health worker systems in areas where there are never going to be enough doctors or nurses to address COVID-19, but can we mobilize these community health worker programs to address this issue? And I'm going to describe one case in Highland, Guatemala. I should point out that I've been working in these villages in Highland, Guatemala since I was a sophomore in college, which is a really long time ago. It's a beautiful place, beautiful people, but deeply troubled with dealing now with the remnants of a 30-year civil war that took place in these areas. And I should point out that if you look at the most violent places on earth, Syria has the highest violent death rate in the world. But right after that is Salvador, Venezuela, Honduras. The most recent data has kicked Guatemala up into the top 5. Then you get Afghanistan, Iraq, Libya, Somalia, South Sudan. The people fleeing the Northern Triangle of Central America to try to cross into our border are leaving some of the most violent places on earth. This is San Lucas Toliman, the communities that where I've been working and that Stanford has had a long-term relationship. And this is the environment that we're working in. Most of the people are landless coffee plantation workers. How do you implement CDC guidelines here? Well, there's been a strong community health worker network, and these are just some of the community health workers in the area that have mobilized to address COVID-19. And these community health workers are local people that have been trained to provide basic healthcare services and basic healthcare education. And they are addressing both the direct as well as the indirect impact. The radical shielding is now being implemented in very early stages in these areas, and we're taking advantage of mobile platforms that Stanford computer science students and faculty here some of the computer science students that were with us. The guy in the middle in the blue shirt, Alejandro Chavez, after graduating, has been working in the San Lucas communities with the Community Health Worker Program now for approximately 4 years, developing mobile platforms that allow us to communicate without having to gather people in these areas, and working on both direct and indirect issues. Indirect, we're very concerned about nutrition, where people, if they can't go into the fields, they can't go to markets to sell their wares, they are at risk of starvation. The nutrition program and the maintenance of chronically ill people is now critically important to the Community Health Worker Program. This is just from a couple of days ago, delivering formula to families where breastfeeding has failed, and food supplements going to hundreds of children every month are now being stockpiled in these communities. Some of the groups that we're working with that are deeply engaged in this issue, and if there are people listening who are interested in doing something important to help support these activities, these are colleagues and collaborators who are doing real work on the ground. Now, just to summarize, working on these issues in these places is a world of contradiction. It's a world of compassion, but also of brutality. It's a world of ideals, but also of nightmares. What I've described briefly this morning is, in essence, the collision between pandemic control and the exercise of power. We are working with colleagues at Stanford, UCSF, around the country and around the world to confront COVID-19 in these extremely vulnerable communities with minimal access to adequate health care and minimal capability to implement preventive protocols. This will likely result in direct effects that appear likely to be devastating, but they will also have profound indirect effects where starvation is a real concern, a real threat. The challenge in confronting COVID-19 is developing strategies that not only recognize the vulnerabilities of these communities, but also their strengths. We should not lose sight of the fact that these strategies are not adequate. I am terrified of what COVID-19 will do to my friends in San Lucas, to the refugees in the camps all over the world, and to the kids in border detention. These people deserve better. They deserve to have the capacity to protect themselves and their families and to seek high-quality medical care if they get sick. This is a crucial issue because someday, hopefully soon, there will be effective treatment and ultimately a vaccine. But our analyses of our analytic group with Lisa, we've been looking at the etiology of disparities in child health for some time. It's taught us some hard lessons. And perhaps the most important in this context is that in highly stratified societies, new efficacious interventions are far more likely to widen disparities than reduce them. As efficacy grows, so too does the burden on society to provide this efficacy equitably to all those in need. The reality, however, is that the better off are almost always the first to get the efficacy in question. A new antiviral, a new vaccine, watch out. Power revels in scarcity. We should right now be crafting policies that ensure equitable provision, which of course is not only an issue of scientific discovery, but also of social justice. It's a reminder that the dual struggles, the struggle for efficacy and the struggle for justice, are always inextricably linked. Thank you.
Thank you, Lisa and Paul. That was extraordinary. And I think the questions that have come in reflect that the impact of this presentation is going to be even, really substantial. There's a number of questions about how people can help and other questions more about the data themselves. I'm going to ask, I think we're going to take the luxury of running over a little bit because we still have over 500 participants. And if we get to your questions, that'll be available on the video. We'll also make sure that we're copying the questions. We'll make sure we get answers to these and we'll post them alongside the presentation. So I know Lisa's had a chance to survey the questions, and maybe you can get across, do some rapid fire answers, and then we'll give Paul a chance as well.
Sure. So thank you very much for the questions that have been posted. I thought one that jumped right out at me was how can older physicians help? I think this is critical. So there are important ways that older physicians could engage. The food bank, as I mentioned, is used to taking about 200 calls a day. They're currently getting 1,000. I would love to work with people to figure out how we could train up some of the physicians about the food bank, its services, its opportunities, and do some phone banking for them. You could do that from home, and I know that they would love that support. In addition, Santa Clara County has a hotline for COVID that is also overwhelmed. They are asking specifically for physicians or nurse practitioners, allied health professionals that would be willing to staff and help take some of those calls. Again, could be done from home with amazing expertise. So those are a couple things that I think would be safe, and people would really appreciate your talents and insights and reassurance about being able to answer some of their basic questions. So that was one. Another question, a couple about school meals. How do people sheltering in place get meals? Or how are those volunteers even out there if they are supposed to be sheltering in place? The food bank has been deemed, and these food programs have been deemed an essential community service. So they are exempted from shelter in place. When people go to get the meals, they stay in their cars and they have to continue to do the social distancing, but it is a permitted activity to go receive the meals and or volunteer to work there. So if people feel like they are in a lower risk group and they would be comfortable working and helping out at the Boys and Girls Club or helping out in other capacities around food distribution, that is something that would be welcome. How are these meals paid for? Great question. This National School Lunch Program is run through the federal government, and all of the meals are paid for through the federal government for schools that have children who live in poverty. And during the Great Recession, people knew that they were going to have high rates of child hunger during the summer. And so at that time, the administration put into place extending school meals through the summer so that schools can still draw down those federal dollars to pay for the meals to give to the kids when school is not in, so they can do it during summer. When this started happening, and we realized that people were going to have to close schools, the administration extended that approach to this current time. So it is still basically the school lunch program that is paying for all these meals, but it is just up to the schools of how they're going to get them to the kids. So what the schools have had to do is really scramble to figure out how are they going to distribute the meals and get the word out to families that they can come get them. So those were some of the school meal questions. The last one I'll address was raised by Steve Alexander. And he says, it sounds like everything's great almost. What else is there to do? And I may have overshot. I meant to convey actually the opposite. In doing all the reading for this talk, I became a little overwhelmed with how difficult I think this is going to be in terms of the amount of people that are going to who've already had their income absolutely decimated, and they haven't been able to work at all. The ability to work from home is an unbelievable luxury, and many of our families in our communities cannot do that. They do not have extensive savings to be able to draw upon at this time. I think the rapidity of which this has happened and the impact shows up in the numbers of people showing up to get these community meals. I think we're very quickly going to be in a very, very dire situation. And so the idea, if I conveyed it, that everything's buttoned up, it's actually, I'm concerned it's the opposite. And I'm hopeful that we can really start to think about some new innovative models to try to address some of these things. And you heard me mention a lot of different people, the School of Education, undergraduates, our IT folks, the subspecialty divisions, all different people, but think of all the people I didn't mention. I didn't mention our medical students. I didn't mention other departments. I really think we need to come together in a really powerful way to mobilize as much as we can to partner and strengthen our communities at this time, because I think the next couple months are going to get much, much worse in terms of economic strain, housing insecurity, and food insecurity in our communities. So thanks for the question, Steve. Appreciate the opportunity to clarify my really deep concern, and actually feeling like there is still so much that needs to be done. The best way to find the information, where it's coming in rapidly every day, is that QR code going to our website. We have information about donating, volunteering, and the community resources. And then you can obviously always reach out to me. Paul, did you have some questions, or Mary, other ones you want me to?
Yeah, no, just real quickly, I want everyone to know how much Dean Miner has embraced everything that Lisa's doing. He's had her come speak not only to all the clinical department chairs, to the basic science department chairs. And so I think we're in a really unique position to bring the entire community together. And of course, just get on Lisa's rapid response team list, and for all the people that really want to have an impact. So thank you, Lisa. We transfer to Paul? Yeah? Thank you. Paul, thank you so much. I can't imagine a better person than you on, internationally recognized as a humanitarian, and having already clearly from your presentation a real voice, nationally, internationally, through the government. So I think there was a great question. What just happened to it? It was the last one. Something about how to make, shoot, it just went away. Something about making humanitarianism a right, shoot. I don't know where it went. I'm having some problem. Oh, okay, here we go. Oh, sorry. I think maybe.
I saw the question.
Oh, perfect. Thank you. Thank you.
Yeah, the question was in addressing the issues that both Lisa and I have presented, when do we begin to consider health as a fundamental human right?
There you go.
And for many of us, we have always embraced that perspective. The crucial issue, I think, is even though we may be home alone, we should never feel isolated, that there are practical, pragmatic things that we can do if we engage with structures, organizations, and colleagues that are active in the field, that have a mechanism, an infrastructure of action that already exists. And the slide I presented with some of our collaborating organizations, which will be available for everybody, I would suggest that you look into these, you connect with these organizations, because they are struggling mightily, not just with fundraising and having resources, but creativity and advocacy and engagement, where many of the people, all the people listening right now, could in fact contribute. Also, never diminish the importance of solidarity. Discovery is crucial, but solidarity is not discovered, it is created. And we have the ability to create a more unified voice and maintain a powerful public presence around the importance of health, particularly for kids, through working together through these organizational infrastructures. Please, by being home alone, don't feel isolated. Seek it out. Connect with Lisa and her colleagues, with me and our colleagues, to help ensure that you never feel isolated, but actually engage in solidarity around some of these crucial issues at this crucial time.
Thank you. That was phenomenal. And can I ask you to tell us a little bit, Paul, I know your reach is much broader than the School of Medicine, and a lot of people may not know about things happening around policy on the other side of campus. Can you maybe tell people a little bit about that?
Sure, thank you. Well, the Health Policy Group, PCOR, Primary Care Outcomes Research, Center for Health Policy is actively engaged, looking both locally as well as globally, to bring analytic capabilities to this issue. Modeling issues, critical analysis of data, and this is extremely active. In addition, the Freeman Spogli Institute for International Studies, FSI, has a variety of very important activities in the diplomatic arena, in the political science, and the legal arena. And in fact, later this afternoon, there's going to be a webinar at FSI, which people can zoom into, discussing what's going on that side of campus, including the health policy groups, modeling activities, and Jason Wang from Pediatrics talking about the Taiwanese experience. But one of the real beauties of Stanford is how intimate all the relationships are between the different schools and institutes. And I have been blessed by very close collaborations and wonderful colleagues across the university, at FSI, at Health Policy, as well as in the medical school and the Department of Pediatrics. And COVID-19 is being addressed by all of these different university components.
Thank you. So the announcement about the FSI town hall, when I know I saw at least an announcement yesterday, late afternoon and the evening, you can go onto that website, register not only for this town hall, but all the upcoming ones. So for people who really want to have greater engagement across the campus, I think that's a wonderful resource. And I think it circles back perfectly to what Lisa talked about in terms of solidarity and expanding our reach. So on that note, I think we'll go ahead and conclude. We still have hundreds of people listening, but I think we've hit most of the questions here. So very much want to thank our speakers, and to make sure everyone keeps an eye for pediatric grand rounds, and that we're really serving the broad community, whether it's advocacy or ethics. And next week, we're going to have a focus on our education, the impact of all of this on education, which obviously is relevant across much more than pediatrics, and to keep checking back and mark your calendar for all the upcoming grand rounds. So with that, I'll thank our speakers and thank all of our participants for the great questions and great engagement. Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.